Today I'm going to be talking about upstream AI, and specifically looking at things like image reconstruction, dose reduction, and predicting the future. And this is a little bit like bringing coals to Newcastle because, of course, you guys have been working on a lot of things in this area as well. So hopefully we can have a good discussion and I can learn something from you as well. So I think our time is a little bit limited, so I will jump in. Let's see if I can actually advance. That would be nice. Here are my disclosures. And as Orr mentioned, I will show some of the work from Subtle Medical. And just to be aware that that's a company that I did found. So I may have some bias in that area, but I think it's interesting and would like to talk about it. And also happy to talk about issues around this in discussion if we have time. All right. Well, I like to sort of think about radiology from the patient's perspective. I spend about 20% of my time doing clinical radiology. And for that reason, I think a lot about how we deal with the processes and how the patient experiences what we do. And you can kind of think about it in this way, that a patient gets a request to get a scan done. They go to the scanner. They have that experience, which I'm sure you guys are all very familiar with. Images are acquired. They may be enhanced or visualized in different ways at the scanner level. We may do analytics on them, although I would say that I think most researchers might be surprised how little analytics we do in clinical radiology. A diagnosis is then made, and then hopefully a proper treatment is given to the patient. So you can think about ways to interact with this pipeline in many different locations, from the pre-imaging stage all the way to the area of interpretation. And AI has been employed in all of these areas. And today, I'm just really going to be focusing mostly on this area of reconstruction, just because we have limited time. I think this is an area that you guys are very familiar with, but a lot of folks tend to think that AI in radiology is only about interpretation. And of course, there are opportunities throughout this chain. I don't want to spend too much time on defining terms. Artificial intelligence has been claimed to be any algorithm meant to solve a problem that's challenging for humans. So you can imagine there's a huge list of things we could consider artificial intelligence. I like to think of machine learning as a subset of AI, where we actually can allow computers to learn without explicitly programming the rules by which they learn. And then finally, I'm going to be talking mostly about deep learning, which is down here, which is a subset of machine learning, and in fact, a subset of supervised learning, in which you train a model in a situation where you know all of the correct answers and you want to have the machine basically mimic those correct answers. And again, I think most of you are familiar with deep learning at this point. There have been lots of definitions, but I think the simplest one is one that can represent a model that can represent complex concepts in terms of very simple and abstract representations using an architecture of multiple connected layers. So in this case, the very simple or abstract representations might be the pixel values of this image, and the abstract concepts you want to represent are what is actually in the image itself. And this is an example with 3 hidden layers, but of course nowadays neural networks typically have many hidden layers, hundreds frequently, and many parameters, so they require very large data sets. So how would you use this in radiology? Well, you could think of it very much in the way that we use AI for identifying natural images. So we might feed in a lot of images. We might break them up into individual pixel values, such as here's a 9-pixel image of the brain, lower resolution than most of our studies, I guess. And then essentially the goal of this trial might be to try to figure out if this is a normal case, there's a tumor, a stroke, or a hemorrhage. And this is an example of a fully connected layer. So all of these little lines represent matrix multiplications and all of the weights associated with that. So you can see there are a lot of lines. There are probably too many for you to even see, even in a very simple network such as this. And it turns out that we don't really use fully connected layers too often, mainly because there are so many weights that it is challenging to have enough data such that we don't end up overfitting our data which means that we end up learning the exact specifics of the data set we trained on. And then when we apply that to new cases, it does not generalize very well. The other problem with fully connected networks is that we lose the spatial representation of the image, which, as we all know, is quite important. We represent, in this case, the image just as one long feature vector, and we don't really allow the network to understand how things are related in space. So for this reason, most of the work I'll be showing involves using convolutional neural networks. And this isn't a new concept. This has been around for a long time. This is a paper from 1989. And the basic idea here is, instead of connecting every single neuron and every single layer to each other, you actually use a smaller group of weights, which is then rastered across the image. And this has several advantages. One of them is that you can take advantage of the local structure. And as most people know, convolutional neural networks are spatially invariant. So if a feature happens at one point in the image and in another place it occurs in another area of the image, that can still be utilized by the network. And of course, that's very important in radiology. The other point is that there are far fewer weights than fully connected layers, so it's much more computationally efficient, and one can use it with smaller data sets. And I think the biggest advances since 1989 with this example has been that we've really learned quite well how to actually train these networks using the process of backpropagation. So, how we would do classification today would look something like this. We would feed in images. We would represent those images here with their values, and then we would have these little black lines, which are the weights of the network. And initially, the weights are all random, and eventually you end up making a prediction here of what the image represents, and you can use that, since you know the answer, since you've had a radiologist or somebody qualified to make that decision. You can train a cost function and use that to update the weights so that the next time you see an image like this, you're a little bit closer to getting the correct answer. And then when you're finally done training the network, you deploy it. As shown here, you fix all the network weights and you just let it run forward. And hopefully what you end up doing is leading to a prediction that is the correct prediction. So in this case, this is a brain hemorrhage, and you would want your network to predict very high likelihood of this being a brain hemorrhage. So this is how we've been doing classification. I think these are the most common algorithms at this point. One thing that I would say is that, how does this represent images? Well, you can think of this kind of 4-class prediction as a small image if you want. This is 4 voxels of an image, and if you knew the truth in each one of those voxels, you could design a cost function to try to optimize that. Not only do you get the right answer in one of the boxes, but you actually get the right answer in all of the boxes. And that is sort of the concept behind image transformation. So the idea is basically very similar to what I just showed you, where you have multiple encoding layers. And instead of then stopping here and flattening the network and making a prediction, one actually builds up the size of the layers again to whatever size you would like, whatever size your final image might be. And then instead of comparing a different class of image, what you're doing is you're comparing the prediction at each voxel. And by doing that, since we know the truth at each voxel, we can actually create a loss function that allows us to train this network. And this is a very common network that one sees. This is called a UNet, just based on its general shape. And people have done variations on this as well. But I just expressed this to give you the general concept. And you'll see a lot of UNets kind of in the background of this talk as we go along. So I want to talk a little bit about imaging reconstruction, but I want to talk about something that often we neglect, at least in the clinical area, and that is acquisition. And one of the things you will learn very quickly if you work as a radiologist is that every technologist is different, and every technologist does their study in a different way. And this is obviously very challenging because as researchers, we try to be very precise and always run the same types of acquisitions. So we kind of take it for granted that that's how the world works. But it turns out that it doesn't work that well. And so this is kind of an example of a video given to me by Bob Hu, who's the CEO of HeartVista, which is a company out here that is basically trying to develop a self-driving scanner. And I think this is really a great concept. It uses machine learning and AI mainly to identify images such that it can then revise things like scanning plane, NTR and TE and things like that, such that a technologist can run a study by pressing a single button. And they don't have to know, for example, all the details of how to run a complex heart exam. But at the end of the day, you end up getting data that is uniform and valuable for all the applications I'm going to show you later. So I think this is still very early technology, but I think that it is incredibly important to realize how dependent all of our models and all of our decisions are on the quality of the initial data that we get. So I think this is a very exciting application. Okay, let's talk a little bit about reconstructing MRI. And I think this is a nice paper by Bill Edelstein in 2010. So it's 10 years old now. And the interesting thing is he gives these pretty good MRI principles. So just some basics that we should all be doing. And I'll let you read them through. And I would say that we do pretty well on most of these, but at least at our place, we don't hit this idea that examination should take 10 minutes of imaging plus 5 minutes of patient handling time. So the idea that he has is that an MRI exam should be 15 minutes long in total. You should be able to do 4 patients per hour. And at our institution, and also as I remember back at MGH, typical exams were between 30 and 45 minutes, and that hasn't really changed over the last 20 or 30 years, despite the fact that we've obviously had massive hardware improvements over time. So how can we think about getting to this number? Because not only is this good for patients who may not be able to stay still, but it's also very good for reducing the cost of MRI, because as you know, MRI is one of the most expensive modalities that we have. And because of that, it ends up essentially being rationed. Okay, so how do we improve image quality? Because if we can improve image quality, we can obviously image faster. And there are 2 approaches. And one is to approach it from the sensor side and the case-based data. And this has been something that people have been working at both at Martinos and out here at Stanford for a long time. And there are a lot of benefits to this, right? You have complex data. You can explore lots of interesting and different sampling patterns. You can put a lot of coils on the outside and use parallel imaging and compressed sensing techniques. I would say the disadvantages of this technique are that you end up having to deal with proprietary data formats from all the different vendors. So if you guys are very familiar with Siemens, it turns out that if your next job is working at a site that has a GE scanner, you may find that many of the methods that you are working on would have to be rebuilt from scratch. So this is very challenging because a lot of places, they don't just have one vendor, they have multiple vendors. For example, you may have GE scanners at the hospital, such as at MGH, but you may have Siemens scanners at Martinos. And I think this is a challenge when dealing with case-based data. The other approach you can think about is starting from the images themselves. Now, these are generally magnitude, but of course you can always use complex images if you like. You can frame the problem here similar to that of natural images. All the things that you might want to do with natural images or video, such as denoising, super resolution. There are a lot of correlates that you can build on from natural imaging data sets. Proprietary data issues are less of a problem, I would say, not completely eliminated, but certainly every vendor has a motivation to produce high quality images. And as I mentioned, this is a vendor neutral approach. So obviously, we've seen both of these approaches out there. I obviously want to highlight the excellent work done at Martinos. You're probably familiar with Bo Zhu's work, which he called AUTOMAP. And I thought this is, a great example of thinking outside the box. So, when I was at Martinos, and I'm sure still, we think a lot about the MR physics that's involved in reconstruction. And it's really kind of radical to think, well, let's just throw that all out the door, and let's think about this as just a sensor to image type problem, and see if we can do this as a learned system without any assumptions about the underlying model. So, that's what was done in this paper. And it had several advantages. You could use natural images to train, and the study demonstrated that reconstruction could be performed for multiple different modalities, as well as multiple different case-based sampling patterns. So, I think this was really a great example of, thinking about a problem in a new way as new methods and new technologies come ahead. Now, of course, since then, we've seen a lot of work in which we've tried to bring in the MR physics back into the equation with terms such as data consistency terms, things that we know about scanners. And one example of this is the variational network that was developed first by Kirsten Hammernick and kind of had the idea of taking, for example, a very small amount of case-based data along with sensitivity maps and starting out just doing the best you can, just zero filling that data, creating an image. And then if you actually had a reference image, a highly sampled, high quality image, one could then use that to basically feed all of this information into a network, learn what the reconstruction error is here. This is that cost function I was talking about before, and then iterate basically and improve the parameters of this variational network such that you get to a better and better reconstruction of that image. And there have been plenty of other approaches in general about how to do this general approach. And just some data from Florian Knoll at NYU, who's taken this further, shows an example in knees. And, it does pain me as a neuroradiologist to show you guys knees because, after a few years outside of general training, I have no idea what kind of anatomy I'm looking at here, except that I do recognize that the deep learning approach probably are the images that I would like to read as a radiologist compared to the parallel imaging or the parallel imaging compressed sensing methods shown here. They also showed, which is that this can generalize to different body parts, so that if you train on a knee, you can actually do a pretty good job predicting brain images as well, which is obviously important because we do lots of different kind of MR studies. And the last thing I just wanted to say is, and you guys are probably pretty familiar with this, is that the NYU group has done a lot of work in terms of sharing data in collaboration with Facebook. And so, this is just, we've tried to do this at Stanford as well. I think everyone here knows the challenges of sharing data outside of your institution, but I would say that one of the nice things about the machine learning and AI community getting involved with radiology has been this emphasis on sharing, and it has been very valuable. So, this is a spot you can go if you don't want to acquire 10,000 knee exams or 7,000 brain exams. You can actually have the case space and the image space representations for you. And you can even play around with things like competitions and the like to see how you stack up against other groups. All right. I want to talk a little bit now about image space, which I've been spending more of my time on. And I want to talk about an imaging study or sequence that actually was what I wrote my PhD thesis on back in at the MGH NMR Center, and that's arterial spin labeling. And this is a non-contrast method for measuring blood flow, which basically works by labeling blood in the neck, allowing that labeled blood to flow into the brain and mix with the normal magnetization of the brain tissue, and then acquire another image without that label, and then essentially just subtract those two images to provide a map of where the labeled blood went, which is in proportion to blood flow, essentially. And if you wait long enough, you can get very pretty images like this, and they're actually quite useful clinically. But one of the challenges we have is that this remains a low SNR technique because only about 1% of the protons are actually replaced by the inflowing blood during the time of a typical examination. And besides that, you then have to subtract control and label experiments, which further reduces the SNR. So how could you use deep learning to try to improve this methodology? Well, one thing you could do is just do a lot of signal averaging, right? This isn't rocket science. What we can do, in this case, this is 6 signal averages, MRI study of the brain. And I would love to do this in every clinical patient that walked through the door, but it turns out that we don't have that kind of time on our scanners. So the question is, could you get a low-nex version of this, a 2-minute scan. Take that, combine that along with other images that you get for free from the pulse sequence, such as low-resolution T2 weighted and proton density images. And can you use this to train a deep network to create a synthetic image that is trained on this very high-resolution image shown on the left? And in fact, it turns out that you can do this. This is just the error maps between the gold standard high-resolution image, high-quality image, and the synthesized image. So you could see it's a much better representation of what you would have gotten if you waited 8 minutes in the scanner. Now, this obviously is not specific to ASL imaging, diffusion imaging. We frequently use multiple nex averaging because we need to build up signal to noise. And this is just an example of deep learning image-based denoising. And a lot of work has been done in this area, and not just for simple trace diffusion imaging, more in the area of diffusion tensor imaging, where the requirement is to get lots and lots of directions to make a good map of higher order information, such as fractional anisotropy, kurtosis, and things like that. And this is a nice paper, one of the earliest papers actually that I've seen using a deep learning approach. And in this case, they actually used a pixel by pixel implementation as opposed to a convolutional neural network. But what they showed was that they could actually reproduce reasonable quality images that would normally have taken 158 or 288 individual acquisitions and actually do that with far fewer number. I think they're looking at like 16-fold reduction here. So again, one of the longest studies that we have is DTI in the clinic, and often patients start to move, and now you've got a long sequence that's absolutely useless at the end of the day. So I think these methods are quite exciting to actually accelerate some of these things that have been researched typically because we can't get them into clinic because they take too long. I also mentioned that, besides denoising, you can think of super resolution. And this is just an example in a 12-year-old with epilepsy. And in this case, the high quality image is on the far left, but you could see the patient couldn't tolerate it. They actually started moving, and you can see the artifacts that are there. But if you have the shorter scan in the middle, which is acquired in about half the time, you can actually learn with many, many pairs of high resolution and low resolution images how to efficiently denoise or to super resolve these images. And I think that these are very interesting, and we haven't done a lot of studies, but a lot of applications, particularly of cortical mapping, a lot of the work that has been done at MGH, is limited in clinical practice because people aren't willing to take the amount of time required to do high resolution images. So maybe this is a way of moving that forward. There haven't been a lot of studies evaluating how effective denoising or super resolution is clinically. And I just throw out this one study that I'm familiar with where that denoising was done in the spine. Spine imaging is very common. And in this case, instead of doing a lot of quantitative measures, which you can do as well, we actually had blinded neuroradiologists review these studies. And in these cases, their opinion was that the fast scans were the same or better than the standard scans on all of the metrics. And in fact, that the deep learning methods had better SNR and fewer artifacts. And in fact, not only Subtle Medical, but other companies such as GE have developed denoising algorithms that are actually FDA cleared and starting to enter clinical practice now. Okay, I want to switch a little now to dose reduction. Dose reduction, I think of mostly in the area of PET because I have been doing a lot of work in the area of PET MR over the last couple of years. I think it's really the ideal modality for a lot of these data-driven techniques because it allows us to acquire all of the different kinds of functional imaging that we can think of with MR and combine that with what is often a very difficult study to do, which is imaging of molecular receptors or metabolism available with PET. So not everyone can have a PET scanner, but a lot of people have MR scanners. So I think that the fact that we can actually acquire this data together makes it a very rich data, an opportunity for these data-driven methods. How have people used deep learning in PET? Well, this is one example from the group at Mount Sinai, and what they have been interested in is basically predicting PET images directly from sinograms, kind of in the way that we showed before for AUTOMAP. And the idea here is that this could replace the very slow iterative reconstruction. So one of the things I would say I was not prepared for when I started working with PET MRI was how incredibly slow and time-consuming these reconstructions are. And if we want to do especially a dynamic scan with multiple reconstructions, we were at a point once in our studies where it was taking us, we could collect more data than we could actually reconstruct, such that every patient we did, we would fall further and further behind in terms of actually getting the data that we needed. So we just had to stop and actually spend time reconstructing. So this is a real need. They use simulated training data, which is another thing that is many groups have used with success, but they showed that it worked well with real patient data. And one of the things that they showed that was a little surprising perhaps is that in addition to performing a reasonable reconstruction, which is shown here on the far right, if you look at it carefully, it actually looks like it may actually have a denoising effect, even though that wasn't the primary goal of the study. I think these algorithms, just from seeing many, many cases, tend to have a denoising application independent of whatever other cost function you apply. All right, let's talk about dose reduction a bit. As many of you know, FDG PET is the most common PET study that's done in the country. And the radiation dose is actually reasonably high. It's between 6 and 32 millisieverts. Just to give you kind of a flavor, the annual background radiation that one gets might be about 50 millisieverts per year. So one group has calculated this has led to an increased cancer risk of about 0.5 to 0.6% per study, which is not very big when you consider the overall cancer risk in most people is about 30%. But still, you know, if you want to do multiple studies, this will add up. Now, PET MRI can eliminate the CT component, which in many cases is greater than 50% of the dose. So that's good. But the question is, you know, can we reduce PET radiation further with deep learning? And just to kind of put things in perspective, this is an example of what PET images look like as you start removing counts from the fundamental underlying data. And at the standard dose, I like to think of in terms of non-contrast head CTs, because we do a lot of those as neuroradiologists. So a standard dose study is 3 non-contrast head CTs. Natural background is somewhat lower than that. And then the real key is, you know, can we get down to dose levels of 20-fold, 200-fold, where we're talking about radiation doses on the level of a cross-country airplane flight, where it would really open up a lot of applications for PET that we don't currently do. So, you know, you might not be surprised. The one approach to this is in the image space, just very similar to what I showed you before. While this does show a fully connected layer network, typically these are done using UNet type algorithms. And here are just some examples of a standard PET done at 5 millicuries, which is already pretty low dose compared to what we used to have. And part of that is the fact that we just have better PET scanners than we used to. In the middle, we have a simulation of 25% dose reduction. And on the far right, you have an example of what this image looks like when it's denoised by deep learning. So you can see the improvement. Now, you might just say that it's pretty easy to denoise scans by doing, you know, spatial averaging, but of course that's really not what you want, because you want to be able to see small features. So, you know, this is just an example that these methods do not just perform spatial smoothing. And this is an example of a metastasis in the liver in a patient with esophageal cancer. And you could see on the faster scan, in this case, when you do PET, you can do it in one of 2 ways. You can reduce the dose, or you can use the same dose and just image for a shorter period of time, which has advantages for things like motion, patient tolerance, and the like. And you can see here, it kind of blends into the noise on the 6-minute scan. but on the reconstructed scan, in fact, you get the desired behavior, which is that the homogeneous uptake in the liver is preserved and the higher metabolism of the metastasis is still visible. As I mentioned, instead of just reducing dose, you can go faster. This is a young person, this is a teenager with osteosarcoma. This is the lesion here in the shoulder. And you can see here, as I reduce the amount of time per bed, the images get more and more noisy, as you would expect. This is the gold standard on the right. And you can see again, applying deep learning to these allows you to restore a lot of the image quality and provide a better image for the nuclear medicine physicians to read. The other thing about PET that's really important is that it is a quantitative technique. So you want to be able to make sure that if you're doing measurements on various organs using what's called the standardized uptake value, which is essentially a ratio of how uniform the dose is and how hot a lesion is compared to what would happen if the dose were spread out evenly across the whole body. You can see that these methods also can preserve the SUV values, which for some nuclear medicine physicians are important for diagnosis. Okay, so reducing dose from PET is one thing. The question when we have a PET MR scanner is, can we also use MR information to improve quality? And this is an example of a dose reduction factor much higher than I've been showing before. This is actually a dose reduction factor of 200-fold. So it means that we kept 0.5% of the counts. And on the left is the gold standard FDG PET image. On the far right is the 200-fold count-starved image. So you can see this is kind of what we're starting from. If we also use MR information, can we do better? Well, let's take a look. On the left, this is the denoising without the MR images, and you can see that you actually do improve the quality of the images, but the image remains somewhat blurry. If you include the high resolution MR information, it turns out that you can improve the spatial resolution. It turns out you don't improve the peak signal to noise very much, but you improve the resolution significantly. And this can be very important when one has an application that focuses on very small regions, particularly of the cortex. All right, to kind of demonstrate that, I want to talk a little bit about amyloid imaging. And many of you may be familiar with this. This is actually a radio tracer that binds to beta amyloid, which is an abnormal protein that we can see in patients with Alzheimer's dementia. It turns out that the presence of beta amyloid in the cortex is necessary, but it's not sufficient for an AD diagnosis. So what does that mean? That means that if I have a negative study where the amyloid tracer does not show uptake in the cortex itself, if you can see these little white areas here, that means that this patient cannot have Alzheimer's diagnosis as a fundamental reason for their dementia. So that I think that's very helpful for considering alternative etiologies. The other thing that's really useful about amyloid imaging is that it builds up in a preclinical period in which patients are not demented. They're clinically normal, but the amyloid is building up over time. So one of the advantages, if you see a study like the one on the left, even if the patient is clinically normal, one of the things we do know is that they're at very high risk of converting to dementia in the future. So this acts as kind of an early warning sign. And as such, it is a very useful biomarker. The other reason it's important is because we do have agents now that we can inject into patients that can go in and remove amyloid plaques. And this is an example of a study with the monoclonal antibody aducanumab, which some of you may be familiar with from the recent gyrations in the Biogen stock price, which has been under FDA review currently. And this is just an example from one of their earlier studies showing that in patients who got a placebo, the amyloid stayed about the same, but if you gave the drug, they actually could remove this, and we could study this with PET. And so, a very exciting thing to watch will be, will the FDA actually approve this drug as a potential first disease-modifying treatment for Alzheimer's dementia because there's quite a lot of controversy in terms of the studies they performed to get to that stage. So we were very interested in whether we could reduce dose for amyloid PET MR with the idea that that may be a very important examination in the near future. And this is the work of Kevin Chen, who some of you may remember. He was a graduate student, did his PhD at MIT and worked at the Martinos Center. And we were lucky enough to have him come out to Stanford. And what he showed was that combining PET and MR is superior to denoising with PET alone. And what he also found was that there was no significant difference between how people read these studies clinically for a full dose study versus a study that was synthesized from a 1% dose image. And this is very important because one of the nice things about amyloid imaging is it's read in one of two ways. It's read as either positive or negative as to whether the amyloid plaques actually do reach the cortex. And so what he showed was that 70% of the low dose, 1/100th dose images were uninterpretable, but that if he added the deep model to this, the accuracy was about 90%. And you might say, well, that sounds pretty good, but if you're making a mistake 10% of the time, maybe that's not really good enough for practice. Well, it turns out that if radiologists actually read the same images themselves twice, they actually have a test-retest on the order of about 90% as well. And that is mainly because there are often these borderline cases where there may be some amyloid uptake and it may be very difficult to interpret. So I think that what Kevin showed was that the performance of a deep learning network at 1% dose was actually quite similar to probably about as well as humans could do on this task. So taking this one step further, the question is, could you actually remove the PET dose completely? Because that would really be the best way to reduce radiation dose. And one of the things that we've been doing a lot of has been PET MRI of oxygen-15 water to measure blood flow in the brain. And this is mainly to try to improve the quality of arterial spin label imaging. And this is the work of Audrey Fan, again, some of you may remember, who did her PhD at the Martinos Center and taken up by Jia Guo later. And the basic idea was, PET is a gold standard for blood flow, but very challenging because of things like a 2-minute half-life for the tracer. You need a cyclotron standing by at all times. And MRI does pretty well at measuring blood flow, but in some cases, especially in areas with slow flow, it doesn't perform so well. So could we fix it with a deep learning network? So the idea is quite simple. Use the simultaneously acquired oxygen-15 water as a gold standard and predict the PET CBF from multimodal MRI, which consists of standard arterial spin labeling and then more advanced multi-delay arterial spin labeling methods. And this is an example of cross-modality contrast synthesis, so MRI predicting PET. And we just usually call it zero dose, although in general that tends to frighten the nuclear medicine physicians a bit when we start talking about zero dose. But essentially, the idea here is that there's enough information in the MR images such that we can make a reasonable prediction about what PET images would look like before we actually acquire them. And here's some examples of that work. On the far right is the gold standard PET study for blood flow. And on the left, I show you what standard arterial spin labeling looks like. And you can see it looks pretty similar. But this is an error map shown here that it's not quite that precise, in fact. If you do fancier arterial spin labeling, such as multi-delay ASL, you can do a little bit better. But training a network is really the best solution for this because you can reduce the error quite significantly. Now, one of the things that we've been able to do with this is to kind of close the loop, which means that once we have trained a model to predict PET from MRI, now we can just start doing this without the PET scanner at all. So we can actually take relevant MRI sequences on our clinical scanners, and we can produce an image for radiologists that represents what the PET image would look like. And we're exploring that not only for cerebrovascular disease, which was our initial application, but also for other applications to see if this is something that is actually useful to them. Moving beyond blood flow, to other areas. We've explored whether it's possible to predict other tracers, such as FDG, which is a measure of metabolism. And this is an example of a study in glioblastoma patients where we've taken T1 post-contrast images, T2 flare images, and ASL images in patients after surgery and tried to predict whether their lesions were recurrent or not. And this is the simultaneous FDG that was actually acquired. And on the far right are the images that were predicted from this model. And you can see they look quite similar, but more importantly, they distinguish the relevant pathology. So on the top, this is a patient without recurrence where you have a cold lesion. And at the bottom is a lesion in which you have recurrence, which is a hot lesion. So I think we're at the beginning of exploring this, but I think it's very exciting to think that that data can be actually synthesized from images that we can acquire much more easily and much more cheaply. All right. When we also talk about reducing dose, we can think about reducing other kinds of dose. So we've spent some time looking at MR contrast. As you guys know, MR contrast is good for a lot of things in MR, including measuring perfusion, as was really pioneered by the NMR Center about 30 years ago. We give contrast in about a third of studies, but I would say there are a significant number of patients who can't receive gadolinium due to poor kidney function. And then more recently, there's been increasing awareness that the gadolinium agents we use deposit in the brain and the body. And this is just an example of deposition in the dentate gyrus of the brain, shown here in a patient who has had multiple contrast agent studies. And we haven't been able to show this is bad for you, but patients are quite concerned. And we often have patients that come to us and say they don't want contrast because they've read in the paper that this is really bad for them. So could we think of ways to improve this and make this a lower dose study? And this is just some work that we started at Stanford and have transitioned to the company more and more. And the idea here is to inject 10% dose. And on the left, you can see this is a patient with a meningioma with a bright contrast enhancing mass. Very challenging to see in either a non-contrast study or even with 10% dose. But it turns out that you can train a network to actually produce an image here that replicates what the 100% dose image would look like. And another example of how a network that wasn't really designed to do denoising actually does a fairly good job at denoising the images as well. So sometimes when I show this work, I feel like this person where I feel like we're doing kind of something that's really hard to do, but you always seem to have people kind of like this who are just not very impressed. They, 10% dose, that's great, but we still have to inject the patient. We could still have the issues with anaphylactic reactions. Could you do 0 dose? And this is a study from Germany recently that has suggested that with the proper MR sequences and training, you might actually be able to replicate the imaging, the dose image, the image that you would acquire with a dose of contrast, despite not actually injecting any of the dose. So I think this is very useful. And we've had sort of mixed success at Stanford, I would say. We definitely have successful cases we've seen, but we have not really seen it work well enough yet, maybe just because we don't have big enough data sets yet. But I think this is a really interesting area to evaluate because it really would be a game changer for contrast MR. All right. I want to finish up by talking about predicting the future. In all the examples I've given you, we've been essentially predicting images that occur at the same time, but there's really nothing fundamentally stopping us from using as an output of these networks images that might appear in the future. So we've spent a little bit of time exploring this. And one example that I'll show you is predicting cerebrovascular reserve. And this is a measure of how well blood flow increases when you give it a challenge. And you can increase blood flow to the brain in a couple of ways. You can have patients breathe CO2. You can have them retain CO2 by breath hold, or you could give them a drug called acetazolamide, which is typically what we do at Stanford. Now, the reason this is important is because you may look fairly normal at rest, such as this patient, but if I give you a challenge, you may not be able to increase the blood flow in the areas where you're already maximally vasodilated. So this is essentially a brain stress test, very similar to a cardiac stress test. And the reason that it's important is because if you have poor reserve, you have a higher risk of cerebrovascular disease in the future. So this may allow us to be more aggressive in these patients in terms of treatment and reduce their risks. So the idea is quite similar to what I showed you before. For the PET-MR studies on blood flow that we've been doing, we not only acquire baseline images, but we then also give acetazolamide, and we measure blood flow after the drug. And so in theory, we could do the same thing we did before, where we take the input images here before we give the drug. And what our ground truth that we're trying to predict is an image of what the blood flow is going to look like after we give the drug. And it's not surprising that we would be using a UNet type structure to do this. So this is the work of David Chen, who was a visiting student with us recently. And some of the examples here in patients with severe moya-moya disease, this is a disease where you have occlusion and stenosis of the vessels leading to the brain. So you often have very severe abnormalities in terms of augmentation. And these are actually the 12 worst cases we've had. At the top is what the blood flow increase in their brain looks like after the drug from the ground truth PET study. And then the second row is the synthesized images that were trained using a deep network. And you can see they don't look exactly the same, but they look pretty similar. And in fact, if you take a look at different regions and you set thresholds for augmentation, it turns out that it performs pretty well at identifying areas with poor augmentation. Now, what are we doing clinically? We're actually doing ASL. And you can see, I told you before ASL was a low SNR type method, but then when you subtract a pre and a post contrast image, it gets even worse. So we really are very excited about using this and potentially allowing you to make an estimate of cerebrovascular reserve, even in patients who you don't want to give the drug to because you don't have time, you don't want to worry about any of the side effects, the patient may have a contraindication or something like that. And then, just a final example, talking about predicting things that occur further in the future. In this case, we're interested in predicting a map of what brain tissue is going to die in stroke about a week after the initial event. And again, very similar to previous methods, we take the data that we think is important before the study, such as the diffusion scans, the perfusion scans, and then our gold standard is a FLAIR image in which a radiologist has drawn an outline of the final stroke volume. And the goal is to predict that lesion. And it turns out that you can do this, and the current methods actually already outperform what we're using in clinical standard, which are these maps shown here on the far right. Now, the thing that I think is really exciting about this work is not so much to show that we can do it, but to use it in a practical way. And one practical way you can think of doing this is to train different models for different treatments. So if you have a randomized clinical trial and half of the patients have one treatment, half of the patients have a different treatment, could you train a model for each different intervention and then see in advance what the patient is going to look like before you give one of the drugs, and that can help you make a decision. So this is just an example of patients, two very similar stroke patients at the top and the bottom, both of which have fairly severe strokes. And we have two different models here, one that was trained on patients that received TPA, which is a IV medication that can remove clots, and then another model that has trained on patients that didn't receive this drug. And you can see at the top, this patient actually, if you use the model in which you give the drug, it predicts a much smaller stroke than if you didn't give the drug. Whereas at the bottom, very similar patient shows that in this case, the model predicts a very similar lesion, whether you give the drug or not. So one question would be, is this the patient that you want to give the drug to? And this the patient that maybe you don't give it to, and you avoid some of the side effects of the drug. And so I give you this example in stroke, which I think is very good first application because the changes happen very quickly. But you can think of this potentially with any type of clinical decision that you have to make, especially if you have the appropriate data. Okay, so I want to finish up talking about ongoing challenges. Everyone's aware of the lack of large publicly available data sets. The NYU group is working towards that. I think Stanford is trying to share data as well. We know how challenging it can be given privacy concerns. This is a bigger issue for classification type algorithms because they can only learn very little from each case. But of course, for reconstruction, we're trying to predict every pixel. So we have a lot of learning that goes on per case. The question of site-to-site variability, if I train a network at your site, which does particularly work on Siemens scanners, and then I bring it to Stanford and try to run it on GE scanners, you know, how well is it going to work? There have been nice studies from MGH showing that performance decreases quite significantly. And I think this is really something that we've been trying to look at, you know, how do you fine-tune networks to try to improve their performance in different arenas, but very important for clinical care, obviously. I want to talk about the high cost of validating these algorithms. You know, we can obviously measure things like peak SNR and similarity indexes, but, you know, they don't always get to the point of whether a study is useful for the purpose that you want to use it for. And there are a lot of edge cases out there about how people use images. So really the only way to do this is to have a lot of cases, have a lot of realistic settings where radiologists, nuclear medicine physicians read these studies and then concur that they're getting the same information. But obviously this is very, very difficult, very expensive, and very time consuming. So I would say this is a major challenge. And then finally, the last thing I want to talk about is the question of instabilities in deep learning for reconstruction. And this has come up a bit. Some of you may have seen this paper, which I feel slightly responsible for because it was edited by somebody from Stanford. And what they basically showed was that if you added small amounts of noise to case space, you can actually end up with visible changes in the reconstructed images that seem to plague deep learning algorithms worse than conventional algorithms like parallel imaging, compressed sensing, or just Fourier reconstruction. Now, we're worried that this could lead to misdiagnoses. I would say that the one thing, if you read this paper, is that you learn that, you know, this is essentially adding noise in a very, very specific way, such that even though you're not adding all that much noise, you're adding it on a pixel basis in just exactly the right way, such that it causes the maximum degradation in the image quality. So this is really a correlate to the adversarial attacks that you may have seen with, say, natural images, where you can change a few, you know, change all of the pixels by a very small amount such that a human still sees a stop sign, but the algorithm then misclassifies it as something else. So I think it's something to be aware of. I think the real question is, you know, how common are these noise patterns in real life? Is this going to be a problem moving forward? I would say that we haven't really seen it in the data that we have actually had radiologists look at. And I kind of wonder if these abnormalities are somewhat like optical illusions, right? Because optical illusions are sort of really kind of tailoring things to fool the visual system in a way, and are really quite edge cases. So this is kind of my favorite example. One of the sort of ways you can really kill a lot of time is by searching for optical illusions on the internet, because there are a lot of great ones out there. But this is one that I found really interesting, which is the green and blue paradox, I guess. And this is that these two, both the green and the blue image colors that you see here, you know, are in fact exactly the same RGB color scale. They're both basically green with a little bit of blue in them. And it's pretty remarkable how well we can be fooled. You know, and I'll zoom this in just to maybe convince you that in fact they are actually the same color if you look closely. But I would argue that, you know, the visual system has been adapted for many years, but it can still be fooled. And I think that's very similar to these algorithms as well. But I don't think that we should necessarily be too concerned about these kind of edge cases as we start to implement these. But I think it's actually, you know, a concern that has been raised moving forward. So in conclusion, I want to leave with you the idea that AI is letting us do things in radiology better than before, and some things I think that are completely new and quite useful. I think image improvement, along with dose reduction and cross-modality synthesis, can be early applications, and are already seeing them enter into clinical use. I really believe there's lots of hidden information in multimodal imaging that we really only scratch the surface of with our own preconceived notions. and that this is a real opportunity to change common assumptions about quality, speed, dose, and safety. And finally, by predicting the future, I think AI is going to let us really use the whole value of imaging for personalized therapies. So I want to stop there. I want to acknowledge all the people that have helped me at Stanford, and thank you guys for listening. I'm happy to take questions.